a discussion with primary bone tumors. Actually, primary bone tumors are divided into benign bone tumors and malignant bone tumors. Bone tumors are most common in males. So let us start with different benign tumors. All start with O mostly. Remember that the benign tumors we start with O. I can see here the name starting with O. Benign tumors, all of them are most common in boys. So let us start with one by one. First one is osteochondroma. You can see here also osteochondroma, which is it is present mainly in the metaphysis of the bone, and it is like a lateral bony projection growth of a growth plate. This is a growth plate. From here you can see it is a bony projection. It is covered by a cartilaginous cap and it rarely transforms to chondrosarcoma. So this is most common benign tumor, especially in the males less than 25 years. Most common benign tumor is osteochondroma. Next, coming to osteoma. Actually there is no picture of osteoma, but remember it is common in middle age. It is especially present on surface of facial bone, skull, mandible. So on face, mandible, like that you can remember. It is associated with Gardner syndrome. You can see it is associated with Gardner syndrome, that is osteoma. Next, coming to osteoid osteoma. This is the osteoma which is present in the cortex of diaphysis. It is actually having a central lucid space and outer oval shape. It is mainly present in adults less than 25 years. It is also most common in males. It is present in cortex of long bones and most common in appendicular skeleton. It is presenting as bone pain, especially at night, and it is relieved by NSAIDs. So if you give steroids, it will get released, and the bone mass is less than 2 cm with radiolucent osteoid core. Next, coming to osteoblastoma. Osteoblastoma diagram is not here, but osteoblastoma is actually the same type of osteoid osteoma, but it will be greater than 2 cm and it is located most commonly in the spine or vertebra. And the histology is similar to osteoid osteoma, but the larger the size, and this pain is unresponsive to NSAIDs. So remember, osteoid osteoma is responsive to NSAIDs, whereas osteoblastoma is not responsive to NSAIDs. Now let us discuss about chondroma. Actually, chondroma is divided into endochondroma and juxtacortical chondroma. Juxtacortical means near the cortex. Endochondroma means inside the in the medulla of small bones and of hand and feet. So it's a benign tumor of cartilage. Actually, in the name you can see chondroma. Next, coming to giant cell tumor. You can see this diagram. Actually, giant cell tumor develops in the epiphysis of a bone. It is most common in 20 to 40 years range of people who are old in that range, and it is most common in knee region. It is locally aggressive benign tumor. It is having a neoplastic mononuclear cells that express Rank ligand. Rank ligand is expressed on osteoblast and reactive multinucleated giant osteoclast like cells, that is osteoclastoma. Actually there's a osteoclastoma. Giant cell tumor is a osteoclastoma. It forms a soap bubble appearance on X-ray. Here you can see this X-ray. This is a soap bubble appearance, and this is osteoid osteoma. You can see osteoid osteoma in the middle, how radiolucent it is. And this one is osteochondroma. Osteochondroma is the most common benign tumor, right? And this is like an outgrowth from the metaphysis, and it is continuous with the bone marrow inside. Next, let us discuss about osteosarcoma. Actually, now we'll come to the malignant tumors. Malignant tumors are osteosarcoma, chondrosarcoma, Ewing sarcoma. 3 sarcomas are malignant. First one is osteosarcoma. Osteosarcoma, you can see it is accounting for 20% of primary bone cancers. The peak incidence of primary tumor is especially in males who is less than 20 years. And it is less common in older adults, usually secondary to predisposing factors like Paget's disease, bone infarcts, radiation, familial retinoblastoma, Lee-Froman syndrome. And this location is, you can see, it is in the metaphysis of long bones, or it is also common in knee region. Especially it is common in the distal femur region and also in the proximal tibia. The characteristics are this is a pleomorphic osteoid producing cells, that is a malignant osteoblast. It is present as painful enlarging mass or pathological fracture, and it is also forming a Codman triangle. So in this diagram you can see this is a Codman triangle. Actually you can see this is growing in the border, so it is pulling away the periosteum layer, so this will lead to formation of a Codman triangle from elevation of periosteum, and it also forms a sunburst pattern on x-ray. You can see here, this is the sunburst pattern, like rays are coming like that. Okay, so this is a sunburst pattern. So very important, sunburst pattern and Codman triangle are shown by osteosarcoma. This is aggressive primary, usually responsive to treatment, surgery, chemotherapy, if poor prognosis for secondary. So it is primary is usually responsive to treatment, but secondary is having poor prognosis. And the surgery we do for this is called en bloc surgery. You can see here the spelling ENBLOC. Okay, en bloc surgery is the treatment. Next, coming to chondrosarcoma. Chondrosarcoma, actually there's no diagram over here. I can show this text to you. Chondrosarcoma is most common in adults who is greater than 50 years. It is occurring in medulla of pelvis, proximal femur and humerus. So it is affecting the proximal bones of femur, of leg and hand, humerus. Remember, it is affecting the medulla. It is a tumor of malignant chondrocytes. As the name you can see, chondrosarcoma. So malignant chondrocytes. It is lytic, that is greater than 50% cases with intralesional calcifications, endosteal erosion and cortex breach. So this is also somewhat like osteosarcoma. It is going beyond the cortex. So it is also leading to cortex breach, endosteal erosion and calcifications. So finally, sarcoma is Ewing sarcoma. In this diagram you can see this dotted. This is Ewing sarcoma. It is mainly occurring in the medulla, especially in the diaphysis of the long bone. It is most common in white patients, generally males who are less than 15 years old. And it affects mainly femur and pelvic flat bones. The treatment is surgery, chemo, radiation. Blood culture and tumor aspirations are sterile. Pathology is like you can see small sheets of round cells. Actually, there are anaplastic small blue cells of neuroectodermal origin. I'll show that in this diagram. You can see here these blue cells of neuroectodermal origin. They resemble the lymphocytes. They differentiate from conditions with similar morphology like lymphoma, chronic osteomyelitis by testing for translocation, that is the T1122. So if you do the T1122 translocation, it is especially detected by using the Fish mechanism. So if you do this, if you get this 1122 translocation, then you can confirm it as Ewing sarcoma. And one more thing is there's an onion skin periosteal reaction that is aggressive with early metastasis. So in the early metastasis, you will see onion skin like appearance, but it is responsive to chemotherapy. So finally is a simple bone cyst. In this diagram you can see here, this is a simple bone cyst. This one. So simple bone cyst is a fluid filled space with fibrous lining around it. You can see it is most common in proximal humerus and femur, and it is present in the metaphysis region, right? Yes, and it abrupt the growth plate, because here somewhere over here the growth plate forms, right? You know how the growth plate forms, that is by fusion of primary ossification center from this side and secondary ossification center, which form a growth plate there. So it may abrupt the growth plate. When a child have this simple bone cyst, it may abrupt their growth. And the treatment is just to observe, X-ray regularly. So when we find out this, then we can, if it is aggressing, it is converting into either benign or malignant tumor, then we can do treatment. Otherwise it is self-limited. So by this we completed the both benign tumors and malignant tumors of the bone. Next, let us discuss about bone metastasis. Bone metastasis is most common, especially in the diaphysis, that is osteoclastic in the case of multiple myeloma and osteoblastic in the case of prostate cancer. One more thing we need to discuss here, which is related, is Langerhans cell histiocytosis. It is actually a eosinophilic granuloma in children. That too, it is most common in skull. It is of myeloid origin bone mass. So don't confuse this Langerhans cell histiocytosis with the bone tumors, because it is also a mass, but it is not a tumor. It is just a disease of Langerhans cell histiocytes. Okay. Now let us continue with osteoarthritis and rheumatoid arthritis. So you can see here, this is a normal synovial cavity. This is the cartilage. This is the bone. Actually, this is a knee joint. So here you can see this is osteoarthritis, which is non-inflammatory arthritis. It is called non-inflammatory, but actually it's inflammatory. Here the WBC count will be less than 2000, so it is called as non-inflammatory arthritis. It is mainly caused because of mechanical wear and tear. That is, if there is overuse of joint, that will lead to osteoarthritis. It is mainly destroying the articular cartilage, and this will lead to degenerative joint disorder. You can see this is an inflammation with inadequate repair. Here the problem is inflammation, but there is no repair. So if there is no repair, that inflammation will prolong, and that will lead to osteoarthritis. It is mainly mediated by chondrocytes. So chondrocytes are nothing but the cartilaginous cells which mediate this degradation, and but that repair is not happening. So that is the problem. Predisposing factor is mainly for the female who is aging, and also obesity which is modifiable, and also joint trauma. Among these predisposing factors, obesity can be modifiable. So if with weight loss, this joint problem may be decreased. And the presentation is the pain is mainly in the weight bearing joints at the end of the day, especially at the night times they may have more pain, and that is improving with rest. So if they take rest, then this joint pain may be decreasing. And there is asymmetrical joint involvement. This is a very key important point to differentiate it from rheumatoid arthritis, because in rheumatoid arthritis there will be symmetrical joint pain, but in osteoarthritis only asymmetrical joint involvement, and the knee cartilage loss begins medially. This is very key characteristic, that the medial side is more painful. The medial side, the joint pain is starting, and there is no systemic symptoms, only joint pain, but no other systemic symptoms. So the joint findings are osteophytes. So here in this diagram you can see this is the osteophyte. This is a like a bone degradation products are released into the knee fluid, synovial fluid. You can see this is the osteophyte, and also there are some loose bodies, and there is subchondral sclerosis. This brown color represents a subchondral sclerosis, and this is a subchondral bone cyst which is formed in between these joints. And the development of, there is also the other development, like there is development of Heberden nodes at distal interphalangeal joint. In this diagram you can see this is a distal interphalangeal joint in your fingers. You can see this nodes, that is Heberden nodes, and there are also Bouchard nodes which are seen in proximal interphalangeal joint. This is a proximal interphalangeal joint. These are called as Bouchard nodes. So if we see a patient having this Heberden nodes, Bouchard nodes with joint pain, then we can confirm the osteoarthritis. And there is also first carpometacarpal joint involved. Remember, that is the first carpometacarpal joint, but not the metacarpophalangeal joint. A treatment is activity modification, acetaminophen, and also can give NSAIDs and intra-articular glucocorticoids. So because why you are giving these medications? Because these are non-inflammatory. Now coming to rheumatoid arthritis, here you can see this is rheumatoid arthritis, the increased synovial fluid, eroding cartilage. You can see the bone erosions, but the main characteristic feature to differentiate osteoarthritis from rheumatoid arthritis is there is a synovial proliferation and the pannus formation. You can see this red structure. This is a pannus formation. It is characteristic for rheumatoid arthritis but not for osteoarthritis. Rheumatoid arthritis usually presents with a 40 to 50 year female with increased WBC. The WBC count is like here 2K to 50K. So this is rheumatoid arthritis. That is, it is an inflammatory condition where the WBC is 2K to 50K. But in osteoarthritis it is less than 2000. That is differential. And next it erodes the articular cartilage and also bone. So that is important. Here you can see the articular cartilage is eroded and the bone is also eroded, and some bone erosion in this diagram you can see. Next it is affected with HLA-DR4. You can remember this with 4-walled room rheumatoid arthritis, like that. And the causes may be tobacco smoking, rheumatoid factor. Rheumatoid factor is actually IgM antibody which is acting against IgG-Fc portion. So that is important here, IgG-Fc portion. And this is anticyclic citrullinated peptide antibody which is more specific. So the patient presents with pain, swelling, morning stiffness. So this is important. Rheumatoid arthritis, morning stiffness. Osteoarthritis is at the end of the day. Pains at the end of the day is osteoarthritis. Rheumatoid arthritis is pains in the early morning. And it is lasting. The pain is lasting for greater than 1 hour and it is improving with use. So rheumatoid arthritis improve with use. but osteoarthritis will decrease with rest. So if you take more rest, osteoarthritis will decrease, but rheumatoid arthritis will improve with use. Like if you're using it more, then your pain is decreasing. So that is the difference. And the symmetric joint involvement, that is again, yes, the symmetric joint involvement, and it is extra articular manifestations are common because it will affect the fingers, swan neck deformity, and also you can see the botanier and swan neck deformity are commonly present along with the rheumatoid arthritis. And next, coming to juxta-articular osteopenia and also soft tissue swelling is seen. Along with this, there is subchondral cyst, joint space narrowing. Deformities are cervical subluxation, ulnar finger deviation, especially ulnar. There is a little finger deviation, and also swan neck botanier involves metacarpophalangeal joint and proximal interphalangeal joint and distal interphalangeal joint, but not the first CMC. And also it involves the wrist, that is important. Rheumatoid arthritis involves the wrist. Here also the treatment will be same: NSAIDs, glucocorticoids, and disease modifying agents like methotrexate, sulfasalazine. Biological agents are like TNF alpha inhibitors. So that is the difference between two. And one more thing point here you can see is the extra-articular manifestation include rheumatic nodules, the fibrinoid necrosis with palisading histiocytes in subcutaneous tissue and lungs. So sometimes if the rheumatoid arthritis progress, it can go to lungs and cause pneumoconiosis, that is Kaplan syndrome, and also it will lead to interstitial lung disease, pleuritis, pericarditis, anemia of chronic disease, neutropenia, and splenomegaly. Splenomegaly is called Felty syndrome. And it may also cause amyloidosis, Sjögren syndrome, scleritis, carpal tunnel syndrome. Next, we'll move on to gout. Let us continue our discussion with gout. So actually, gout is a condition. It is an acute inflammatory monoarthritis caused by precipitation of monosodium urate crystals in joints. So in this structure, you can see these are the urate structures which you can see in the joint. So they are accumulating. They are like needle shaped. You can see. Actually, they appear yellow on parallel light. How to remember it? Yellow, double L. So yellow means parallel. Here you can see double L, parallel double L, whereas blue in perpendicular. Perpendicular is blue. So this blue is perpendicular, yellow means parallel. So it's an acute inflammatory condition mainly seen in males, and it is associated with hypertension, obesity, diabetes, dyslipidemia, and also alcohol use. You can see it here. And the strongest risk factor is mainly hyperuricemia. So gout means nothing but hyperuricemia. That is, the uric acid is getting accumulated. There may be two reasons for this. That is under excretion of uric acid. Uric acid is not getting out. So 90% of the patients have this problem only. That is largely idiopathic. It is potentiated by renal failure. Cause of gout may be uric acid overproduction. So overproduction is seen especially in Leach-Nyhan syndrome, where there is a presentation of a male child with self-mutilation and gout and motor syndromes, and also sometimes there may be PRPP excess and also increased cellular turnover, like which is seen in tumor lysis syndrome. And von Gerke disease. What is this? Actually, von Gerke disease is a G6PD deficiency. That is, you get hypoglycemia between meals. So even though you are eating meals, again in between that meals also you'll get hypoglycemia. It is especially seen in infants. So it is associated with seizures, lactic acidosis, and URAT1. Okay, next coming to we know that these crystals are actually needle shaped, and they are negative bifringent under polarized light. So they are appearing yellow in parallel. How to remember that? Double L and yellow, double L in parallel. Okay, and blue in perpendicular light. And serum uric acid levels may be normal during an acute attack. Actually, the problem in the gout is, you can see here, the crystals are phagocytosed by macrophages, and this trigger the inflammation, and this is most common in cool temperature, and some genetically it is also affected somewhat genetically. Next symptoms are urate nephropathy, that is the uric acid crystals are present in urine, and this also may lead to uric acid kidney stones, which is also associated with chronic renal failure. Gout is divided into primary and secondary gout. Primary gout is mainly due to under excretion of uric acid. Secondary gout is due to rods or some medication. I mean this crystals accumulation or due to some medication. Next, alcohol, URAT1, all this ATP, lactic acid, all this increase uric acid. Especially lactic acid increase uric acid by reabsorption of uric acid from kidneys. And gout attacks are most common in obese male. So case obese male is always affected with gout. Diagnosis, you can do arthocentesis. In that you will get the WBC count will be between 20k to 50k. Always remember, if the WBC count is 20 to 50k, it will be gout, or also it can be rheumatoid arthritis. So you know already how to differentiate them, right? So here you can see I wrote the WBC counts. If the WBC is 200 to 2000, it is osteoarthritis. If WBC is 2k to 50k, it can be rheumatoid arthritis, also gout. Okay, whereas WBC is greater than 50k, that is for sure septic arthritis, because the organisms are involved. So WBC will increase a lot here. So here now coming to calcium pyrophosphate. Actually, calcium pyrophosphate will get accumulated. You can see this diagram. This is the accumulation of pyrophosphate. Actually, they are rhomboid shaped crystals and they are positive bifringent. So it is reverse of gout. In gout, you get the crystals which are negative bifringent. Here they are positive bifringent. As a positive bifringent, here the parallel when parallel it will be blue, and there you know when parallel it is yellow. Here when parallel blue, and when perpendicular it will be yellow. So it's a reverse of gout. So this is called as pseudo gout, especially seen in a patients who are greater than 50 years, and this is most common after parathyroidectomy, or who are having hyperparathyroidism or joint trauma, or associated with hemochromatosis. What is hemochromatosis? It is actually iron overload disorder. It is most common in metacarpophalangeal joint. It is associated with pain, swelling, and especially you'll see this in young patients where they're having high ferritin levels, hence hemochromatosis. And this whenever this crystals calcium pyrophosphate deposit, that will lead to pain, swelling, acute inflammation, that is pseudogout. If there is chronic degeneration of the joint, that is pseudoarthritis. You know, in osteoarthritis also there is degeneration of joint, but here it is pseudo because it is not due to real osteoarthritis, is due to this calcium pyrophosphate deposition. And most commonly affected joint will be the knee. There is a progressive cartilage deterioration. And the chondrocalcinosis is cartilage calcification. You know, there's a hyaline cartilage which will get calcified. And the crystals I already discussed. The treatment is NSAIDs, colchicine, glucocorticoids, prophylaxis, colchicine. So this treatment is same like a gout. But there are some associated conditions with the pseudogout, like joint trauma, hyperparathyroidism, hemochromatosis, arthritis, especially iron deposition in synovial tissue. Calcium pyrophosphate may also deposit. It is seen in 2/3 of patients. So you can see this 2/3 of patients only have this kind of problem. And in gout, I forgot some points, like always remember it will affect only asymmetrical joint. Okay, and tophus formation is common. You can see this is the tophus, which is often seen on externally and occur on the Achilles tendon. Okay, acute attack tends to occur after long meal, like foods which you eat which are rich in purine, for example seafood and meat. They may lead to this problem, because actually after eating this food, they compete for the same excretion sites in kidney. So because of that, what happens, uric acid will get accumulate, and that will lead to decreased uric acid secretion, and that will build up in blood, and that will lead to problems of gout. So gout is most commonly seen in renal failure, because you are unable to excrete uric acid. Diuretics, because we prevent diuresis, so we prevent its excretion. In volume depletion and also in myeloproliferative disorders, there will be increased amount of uric acid. Next, continue with systemic juvenile idiopathic arthritis. In the name itself, you can see it's a juvenile, that is a child less than 16 years old is usually affected in this kind of arthritis, and it usually presents with they have daily fever. You can see here they're having daily fevers, and they're having a salmon pink macular rash, which is characteristic. And arthritis involved more than 2 joints, so you can say it's a oligoarthritis, and it is associated with anterior uveitis, and it is presenting with leukocytosis, thrombocytosis, anemia, increased ESR, increased CRP. So treatment is NSAIDs and also methotrexate, TNF inhibitors, and you can also give steroids. Next, coming to another disorder, the septic arthritis. You can see how inflamed the joint is. You can see only one side it is involved. So it is a monoarthritis. Mainly it is septic. Septic means organisms are involved, like Staph aureus, Streptococcus, Neisseria gonorrhea. These are the common causes. It is unilateral, and affected joint is always swollen, red, painful, and the synovial fluid is purulent. So if you take out the WBC and check out, it will be about like a greater than 50,000. So the treatment is, for sure we should give antibiotics, we should do aspiration and drainage to prevent the irreversible joint damage. Okay, so especially you can see here the disseminated gonococcal infection, that is the STIs, which that present as either purulent arthritis, that is seen in knee, or a triad of polyarthalgia, tenosynovitis, that is seen in hand, and dermatitis, which are forming pustules. So this may be the causes of disseminated gonococcal infection, which is also involving the joint, that is septic arthritis. Next, let us continue with seronegative spondyloarthritis. So, in the name itself, you can see seronegative. Seronegative means here the rheumatoid factor is negative, that is the IgG antibody is absent, and it is spondyloarthritis. So, spondyloarthritis means it is involving mainly the spine, right? Spondyle means spine, okay, and it is asymmetric oligoarthritis. So first we need to understand some terms related to arthritis. Polyarthritis means if you involve more than 5 joints. Monoarthritis means 1 joint. Oligo means 2 to 4 joints. So this seronegative spondyloarthritis involves mostly 2 to 4 joints. It is asymmetrical. You can see this most in the lower extremity, and it is autoimmune mediated by T cells. Mainly T cells are involved here, and it has a MSK class 1 serotype. So you can remember this subtypes with a mnemonic pair. So P for psoriatic arthritis, A for ankylosing spondylosis, I for inflammatory bowel disease, R for reactive arthritis. And main thing you need to see among all this disease, all these pair diseases, is they have the inflammatory back pain, because it is a spondyloarthritis and it is associated with morning stiffness, but it will improve with exercise. And you can get peripheral arthritis and enthesitis. So what is this term enthesitis? That is inflamed insertion site of tendons. You know that tendons insert at specific site, that sites will get inflamed. Example, you can take Achilles, which is present in our leg, right? And dactylitis. Dactylitis means the fingers will become inflamed, and that is called sausage fingers. And uveitis, which is involving eye. So and also sacroiliac inflammation is involved. And one more thing is that this all pair are involved with a gene that is HLA-B27. They're strongly associated with HLA-B27. So let us start with psoriatic arthritis. In the name itself, you can see psoriasis means it is a skin involvement, and along with that there is arthritis. So you can see here, this is the skin involvement which you see in psoriatic arthritis, that is associated with nail lesions and skin psoriasis. Means it is asymmetrical and patchy. It also may involve dactylitis, that is the fingers may become swollen like sausages, and especially you can see the penicillin cup deformity in the distal interphalangeal joint. You can see here this is a penicillin cup deformity, this red arrows are showing. And also associated with hyperkeratosis and ankylosis. Ankylosis means the nails can get easily separated from the nail bed. Okay, and this is seen in only fewer than 1/3 of patients of psoriasis. So psoriasis may sometimes lead to these problems, along with this psoriatic problem and distal interphalangeal joint and ankylosis, all this. Next, let us discuss about ankylosing spondylitis. Actually, this is mostly involved with the HLA-B27 gene. You can see here I wrote HLA-B27 positive. So the people who are HLA-B27 positive will never get this disease. Actually, the problem here is there's a new bone formation in the spine. So if the new bone forms suddenly, what happens is the spine becomes stiff. As the spine becomes stiff, there are different problems occurring, like it is symmetrically involving the spine and sacroiliac joint. So ankylosis is joint fusion. It will lead to uveitis, aortic regurgitation. It is most commonly seen in males of 20 to 30 years. Here the ESR and CRP are increased. Here also you can see enthesis and dactylitis. And one more thing is bamboo spine is characteristic. Bamboo spine is characteristic of this disease. It is a costovertebral and costosternal ankylosis, may cause restrictive lung disease. In the case of lung, costovertebral, costosternal, if the new bone is added there, then it will lead to restrictive lung disease. So we need to monitor the chest wall expansion for this disease. And next is inflammation of back pain may improve with exercise in this case. Next, let us discuss inflammatory bowel disease. Inflammatory bowel diseases like Crohn's and ulcerative colitis are often associated with spondyloarthritis. They are divided into type 1 and type 2. Type 1 is less than 5 joints are involved, that is the large joints are involved like knee, hip, and they are dependent on GI conditions. Whereas type 2 also there's greater than 5 joints involved, but hand and small joints are involved. It is independent of GI system. Next, reactive arthritis. Reactive arthritis occurs days to week after infection. So here there's infection. Here there's a classic mnemonic like we can't see, can't pee, and can't bend my knee. That is can't see conjunctivitis, can't pee, that is urethritis, can't bend my knee, that is arthritis. So CUA. These are the classical triad. Sometimes also associated with Relter syndrome. Here also asymmetrical oligoarthritis, most common lower knee, inflammatory lower back pain. Of course, these are all spondyloarthritis subtypes. So for all of them, there'll be lower back pain. And this mnemonic, as I already show, can't see, can't pee, can't bend my knee. And the infections, what infections are mostly affected? Shigella, Campylobacter, E. coli, Salmonella, Chlamydia, Yersinia. Now comes polymyalgia rheumatica. In the name itself, you can see poly means many myalgia rheumatica, many body pains. Okay, so symptoms are like pains and stiffness, especially in proximal muscles like shoulders and hip. So it involves mainly the shoulders and hips, associated with fever, weight loss, muscle weakness. It is most commonly seen in females of 50 years old, and it is worse especially in the morning and difficult in dressing. This is most commonly associated with giant cell temporal arthritis. So here the findings are ESR is rise, CRP is rise, but the creatine kinase is normal because there is no breakdown of muscle here. Only when muscle breakdown, then creatine kinase will rise. Treatment is rapid response to low dose glucocorticoids. Next, coming to fibromyalgia. Fibromyalgia is also most common in females. It is a chronic, widespread musculoskeletal pain associated with only tender points. Only some specific points will get pain here. But here in polymyalgia rheumatica, all proximal muscles will get pain, like shoulders and hips. But here myalgia, there are specific tender points where you will get pain and also tingling sensation, poor sleep, fatigue. Important association it, this is always affecting the cognitive behavior. So whenever there's disturbance of cognition, we need to give antidepressants here, and we need to also say the patient to have regular exercise, and also we can give neuropathic pain agents like gabapentin. Here the inflammatory markers are normal, that is the difference. Here the inflammatory markers are rising, here the inflammatory markers are normal. Next, coming to polymyositis or dermatomyositis. Here also you can understand myositis. Poly means again many are involved. Dermato means something skin is involved. So polymyositis is non-specific markers are increased like ANA, CK, and also there is involvement of anti-Jovan antibodies, anti-SRP antibodies, and all this anti-MI2 helicase. So polymyositis is actually involving the inflammation of endomysium of the muscle. It involves especially CD8 positive T cells and most often involves shoulders. Dermatomyositis, I can see the word dermato, it is related to polymyositis, but also it is involving the gutron papules. You can see skin. In skin here, you can on the hands, you can get gutron papules, and also this photo distributed facial erythema. You can see the facial erythema, and especially involving the upper eyelids, that is called as heliotropes, and also it involves the shawl and face, this area, shawl and face rash, and also cause mechanical hands like thickening, cracking, dry appearing marks of skin. You can see here how crack and thicken the skin is. So there's also increased risk of malignancy in these patients. Here the problem is, in the dermatomyositis, the problem is the perimysium is getting inflamed. Here the endomysium is getting inflamed. So there is also atrophy with CD4 positive T cells. So in polymyositis, CD8 positive T cells. In dermatomyositis, CD4 positive T cells. And there is a macular rash, shawl and V signs. Next, coming to myositis ossificans. It is a heterotropic ossification involving skeletal muscle like quadriceps. It is associated with muscle trauma, present as painful soft tissue mass. Imaging, you will see especially eggshell calcification. Histology is metaplastic bone surrounding area of fibroblastic proliferation. It is benign but may be mistaken for sarcoma. Next is inflammatory myopathy associated malignancies. Most common adenocarcinomas are associated like cervix adenocarcinoma, lung adenocarcinoma, ovaries adenocarcinoma, pancreas adenocarcinoma, bladder adenocarcinoma, stomach adenocarcinoma. All these adenocarcinomas may be in association with this inflammatory myopathies. We already discussed about this neuromuscular junction. So there are some diseases associated with this. Two diseases. One is the myasthenia gravis. This one shows, this side shows myasthenia gravis. This side shows the Lambert-Eaton syndrome. This side shows the Lambert-Eaton syndrome. In myasthenia gravis, actually the autoantibodies are against this acetylcholine receptor on postsynaptic membrane. So because of this, you can understand if there is no acetylcholine receptor, even though there is a release of acetylcholine, it is unable to take up this. So because of this, the muscles will become weak, especially the proximal muscles become weak, and it affects mainly the eye muscles. So it will lead to ptosis, diplopia. So if you repeatedly stimulate this nerve, what happens is the acetylcholine release will drop because you are repeatedly stimulating it, but there is no receptor to take it. So even though if you release more of the acetylcholine, then that will lead to decrease in acetylcholine on repeated nerve stimulation. And this disease will worsen with muscle if we are using more muscle, but the disease will become worsen because you're trying to use the muscle, but there is no acetylcholine in the muscle, so we can't get the enough acetylcholine, and that will worsen the muscle use. And this may also lead to some you can see this process may also lead to some respiratory muscle involvement, leading to dyspnea, bulbar muscle involvement leading to dysphagia, difficulty chewing, spare reflexes. And it is also associated with thymoma, thymic hyperplasia. For this we need to do CT MRI, and we can treat it with thymectomy. ACE inhibitor administration. So what we do is we inhibit the ACE inhibitors here. Actually there is acetylcholinesterase inhibitor which converts the ACE into some other products, but here we stop that so that more of the acetylcholine will be available for the receptor. So reverse symptoms are like predostigmine and neostigmine and rofenium, which are acetylcholinesterase inhibitors which increase acetylcholine in synapse. There's a test we do is Tensilin test, which is a symptoms will get reversal by using this test. Here the acetylcholine is increased, it activates the parasympathetic nervous system, that will lead to salivation, abdominal cramps, asthma, and also bradycardia. So next, coming to the Lambert-Eaton syndrome. In Lambert-Eaton syndrome, the problem is that there is an autoantibody against the calcium channel. So if there is no calcium channel, there will be no acetylcholine vessel formation and release. So because of that, there is less amount of acetylcholine, but the receptor is normal here. So here what happens is there's a proximal muscle weakness which is most common, and autonomic symptoms like dry mouth, constipation, impotence, hyperreflexia. But if you use this muscle more, the muscle will get better here because you are using the muscle more, so you are demanding more acetylcholine, so somehow some of the acetylcholine may come. And the paraneoplastic syndrome like small cell lung cancer is associated with this. There the thymoma is associated, right? But here this acetylcholine inhibitor have minimal effect because even though you inhibit it, but first there is no acetylcholine to release, so it is minimal effect. But the tensilin test will increase acetylcholine, so more contraction. So tensilin test will give improvement in the case of Lambert-Eaton syndrome. And the treatment is guanidine, which is inhibiting potassium channel, so that can increase acetylcholine release, and that will lead to decrease somewhat the muscle weakness, proximal muscle weakness. So by this we have completed our whole musculoskeletal system first aid revision. In next video we'll start about hematology and oncology.